Welcome to Prep and Play, where we have conversations about safer sexual pleasure. This podcast is dedicated to empowering listeners through open, honest discussions surrounding keeping our minds, bodies, and spirits healthy while being sexually active.
Now, one thing I do want to touch on real quick is how some of these medications work. I mentioned earlier interrupting the life cycle. There are, I believe, 7 classes of HIV medications right now. I'm not going to try and rattle them off the top of my head because I'm going to end up butchering some of these names. But 7 main classes, and each of those classes affects the virus in a different way. You have one class that keeps the virus from being able to latch on to the host cell. You have another class that thickens the cell wall so that once the virus gets inside the cell, it cannot replicate inside and burst the cell to spread. You have another that prevents it from being able to replicate that RNA inside the cell. There's a bunch of different types. There's even one based off of, we know now there are also people who are immune to HIV. They carry what's called the CCR5 Delta 32 mutation. And they've created a class of HIV medications based off of that. They're CCR5 antagonists. And what they do, that CCR5 Delta 32 mutation, it's a modification of the receptors on your cell, essentially where those cells lack the receptor required for HIV to latch onto. And that's actually the class of drugs that caps that receptor for people who do have that receptor so that HIV cannot latch on and replicate in it. And if HIV can't replicate within the cells, it dies out pretty quickly. Now, unfortunately, none of these are a cure. We can't get it to die out completely, but they are really, really close to it. Speaking of cures, even though there isn't a really viable cure, we do know that we have cured people of HIV. There's a couple of folks. The first two went by the Berlin patient and the London patient. The Berlin patient, almost 20 years ago now, he was living with HIV and he was diagnosed with, I believe it was lymphoma. And as they were going through his lymphoma treatment, the doctor decided to try something a little novel at the time and decided to find a bone marrow donor for the lymphoma treatment who carried that CCR5 Delta 32 mutation. When they did the bone marrow transplant from the person who carried that mutation to the Berlin patient, his body started producing HIV-resistant blood. In that, his last day of medication was the day of that transplant. And he lived until, I want to say, about 15 years and was considered HIV-free when he passed in 2020. There's another, the London patient, who, similar situation, living with HIV, diagnosed with a cancer. They did a bone marrow transplant from someone who was carrying that CCR5 Delta 32 mutation. And he stopped his medication about a year after that transplant. Has been off the medication now, I want to say close to 15, 17 years, and is still considered free of HIV. From there, there's about 4 or 5 other people that they've done this to. So they know it is possible. There's a cure out there. But with that particular one, it's just not viable. You'd have to have a unique donor for every person living with HIV that was a bone marrow match for them, that also carried that mutation. And there aren't that many people with that mutation. It's theorized that the people carrying that mutation had family that survived the Black Plague in Northern Europe, because those folks are generally immune to the Black Plague and smallpox as well. But as I said, there's not that many people with it.
Yeah, that makes a lot of sense. And so how has antiretroviral therapy and U=U influenced policies and efforts regarding HIV prevention?
So it's really given us the kind of a renewed hope. And in that, when it comes to public health, we want to make sure that everyone knows about U=U. It's a game changer, especially when it comes to stigma towards people living with HIV, but it also lets people know that it's not something they have to be as afraid of. And it also, for people living with HIV, they've done studies that show that when someone knows about U equals U and is living with HIV, they have better outcomes than people who do not know about U equals U. We also see things like higher self-esteem and self-confidence, a more positive view of themselves, and all of those things, believe it or not, actually lead to better medical outcomes. When you have that self-confidence, when you believe in yourself, when you have that self-esteem, you take care of yourself better, and that in turn leads to better medication adherence. It leads to making sure you go to your doctor when you need to. It leads to making sure you're taking care of yourself in other ways, like eating the right things, exercising, taking care of other health needs as well, blood pressure, diabetes, anything like that. So we know making sure that folks who are living with HIV knowing about U equals U has that positive effect. We also know that making sure that people who are at risk for HIV, knowing about U equals U leads to better outcomes as well. It leads them to start asking questions of their prospective partners. If they know about U equals U, then they know they need to start asking about, what's your HIV status? If you are living with HIV, are you undetectable? Are you virally suppressed? And that leads to lower transmission. It also leads to people getting on PrEP. When we start that conversation around U equals U and ART and PrEP and the advances that we've made, a lot of times we can get people on PrEP if they're at risk for HIV and lower that risk for HIV. As far as policies go, one of the big things in policy that we've seen is part of the Affordable Care Act made sure that HIV medications and prevention had to be covered. Now, that's something that's actually going up for debate and has been a recurring debate with the Supreme Court and the ACA, is the ACA being forcing insurance companies to cover preventative treatments. And one of the biggest arguments on that is with HIV. It costs much less to make sure insurance is covering someone's PrEP than it does for insurance to cover their treatment. Lifetime averages, the last I heard, was HIV treatment is going to run about $500,000 a person. And honestly, I think that's a low-end estimate. I think that's a really low-end estimate. Some of these medications can run, $10,000, $12,000, $20,000 a month. So that $500,000 estimate seems like either a short lifespan or a really undervalued estimate. But with that, we've made sure that insurance has to cover treatment and prevention because it does lead to better outcomes. It's also part of the push for better sex ed in schools, and covering things like STIs and HIV. We still have people in the country who think that HIV is just a gay disease. It's just a gay problem. We know now it's not. It affects everyone. And in fact, the people that are most susceptible to HIV right now are not gay men, but are Black men and women. We're seeing rising rates among those communities, and that has nothing to do with homosexuality or anything like that. It has to do with sex ed and access to health care and those types of things. So knowing about U equals U and the advances has really led us to a renewed push for better sex ed in schools and really anywhere.
And so talking about those common treatments, what would be the difference between first line and second line treatments?
So first line treatments are going to be your almost what a lot of people consider your blockbuster drugs. Those are going to be things like Biktarvy and Dovato, your single tablet regimens that providers prescribe first. It's going to be the things that's where you immediately go when you start treatment. For us, Biktarvy and Dovato are the two main ones in our clinic. And those are the ones that typically work for everyone, have a high efficacy rate, low side effects, and are fairly accessible. Those are our first lines. There's a couple others as well. Some other single pill regimens that are fairly accessible. But second line treatments are going to be the treatments you go to if, for some reason, those first line treatments don't work for you. There are instances where someone may contract a strain of HIV that is resistant to certain medications. So that would be an instance where they would go to one of the second line medications. There also are instances where they may be started on a first line treatment, they continue on it for a while, but then for whatever reason, they have issues with adherence. And those issues with adherence can cause resistance, the virus to have resistance within themselves. And that can require a medication swap. It can require a booster to those first line medications, or it can require higher doses. So those second line treatments are going to be your higher dosages, your boosters, your more complicated regimens for when people have resistance to the initial treatments. But a lot of times, today's first line treatments are going to be tomorrow's second line treatments. We're seeing advances in treatments all the time. When I started at this agency and working in HIV, the common thing was an HIV medication had to be 3 or more drugs from 2 or more different classes. That you saw things like Genvoya, which had 3 medications from 2 classes in it. You saw Stribild, you saw Triumic, which all have 3 or 4 medications from at least two different classes. But now we're seeing medications that are just as effective with only 2 drugs. And that's like Dovato. It's dolutegravir and then another medication in it. And so we know less in this case is actually more. Same with our injectables. Most of the injectables now are just 2 medications. And that's something, it's a big jump. But as I said, a lot of those second line medications now were first line medications 3, 4, 5 years ago. But now we've learned, we can start with less than what we used to, and then fall back on those others.
And speaking of those injectables, what are some things that are on the horizon for the future of HIV care?
So right now with the injectables, we saw approval a couple of years ago of cabotegravir as both treatment and prevention. You see it as Cabenuva for treatment and Apretude as PrEP. And through that, we've seen gradually the space between injections has increased. When they first approved Cabenuva, you had to go and get that injection every month. Now it's every 2 months. Same thing with the PrEP. We've seen longer and longer spaces. We're also seeing new injectables on the horizon. One of the newest ones that a lot of people in our field are talking about right now is called lenacapavir. Over the summer at the International AIDS Conference, they started publicizing the research around that, and that's going to be an injectable that's once every 6 months. So we're talking 2 injections a year, and that can manage someone's HIV and keep them at viral suppression or that undetectable status. There's also a PrEP aspect for lenacapavir as well. That's going to be similar, a shot every 6 months, or with PrEP, maybe even longer. And that's going to effectively prevent someone from contracting HIV. In these, with Cabenuva, it is still a 2-drug regimen. With Apretude, it's the single drug cabotegravir. And with lenacapavir, it's going to be a single drug as well, from what we can tell right now. And so it's those advances, learning that less is more, and we don't have to treat it with as much as we thought we did. Now, looking forward into the future past that, they're still researching into a cure and a vaccine, but if you ask most people who are working in the field of HIV vaccines how far off we are from it, they're probably going to say 2 years, and they've been saying 2 years since 1985. As much as they've tried, they haven't been able to come up with an effective HIV vaccine. These long-acting injectables are actually the closest we've come. But the good news is all of that vaccine research wasn't a total waste. Most of that vaccine research has gone on to lead to vaccines for other things. The COVID vaccine, one of them actually came out of research for an HIV vaccine. Some of our other vaccines that we have came out of that initial research where they found that it didn't necessarily work for HIV, but it worked for other things. So we've had that added bonus as well. With that, I kind of mentioned the cures earlier, that they aren't widespread viable, but there are cures out there, and it's promising. It gives us a direction to work towards. They're also looking for, and this is kind of the intersection between vaccine and cures, things like gene and cell therapy, stem cell research, things like that, that may give us what we need to finally get that cure, to get that vaccine.
Well, that's a very hopeful future that we're looking at in the development in the field of HIV care. You know, we've talked a little bit about the historical context of the emergence of HIV, some advances in HIV treatment and care, and the significance of U equals U, as well as some of the hopes for the future that we have as far as treatment and prevention go. I just want to reiterate, you know, with the development of ART and the understanding that when someone is virally suppressed, they can't transmit the virus, getting tested is more important than ever, because once you know you have it, you can do something about it. And so if you would like to get tested and you're in the Mobile area, you're always welcome to come down to AIDS Alabama South to get tested. Our clinic hours can be found online. And if you're not in the Mobile area, local health departments are usually available to do STI and HIV testing.
You can also Google HIV testing, and it'll typically bring you to a result that's close to your area. You can also go to hiv.gov, and on there, they have tools for finding HIV testing in your area. Everything from private providers to nonprofits like us and public health departments. It can tell you where to go and, in a lot of cases, how to go about getting that test.
Well, awesome. I'd like to thank Chance for joining us today.
Thank you for having me.
Thank you all for listening, and stay tuned for our next episode where we discuss living with HIV with someone who is living with HIV. Okay, thank you.